Whereas in case of retinitis, we'll get this whitish fluffy mass which will have severe vitritis most of the times, and we won't be able to see the retinal vessels. Also, OCT, sometimes it is very important to diagnose the case of retinitis if we are confusing it with choroiditis. So on OCT, if we take a scan through that lesion, we can see the presence of thickened retina and along with increased hyperreflectivity, whereas the choroid will appear completely normal. So now I'm going to discuss some of the important viral retinitis causes. So one of it is CMV retinitis. So CMV retinitis is the most common opportunistic infection in AIDS or immunocompromised patients. It's usually seen when CD4 count goes below 50 cells per microliter. And in patients with HIV or patients with organ transplant, those patients who are on steroids, they usually will have such kind of presentation. So there are 3 types of clinical presentations. The first is fulminant type, wherein we'll have this wedge-shaped area, also called as pizza pie appearance, wherein we'll have this fluffy white lesion with multiple scattered hemorrhages, also known as brush fire appearance. The second is a granular variety, wherein there will be such granular appearing retinitis lesion. There will be very few hemorrhages. And the third is frosted branchiangitis, wherein the retinitis would be along the vessels or along with perivascular sheathing. So in a pre-heart era, the incidence of CMV retinitis was 25 to 42%, but after heart therapy, the incidence decreased by 75%. It also led to slower progression of the retinitis, and it reduced the HIV viral replication. Coming to the treatment, the drug of choice is ganciclovir in CMV retinitis, which is a virostatic drug. It inhibits the viral DNA polymerase. It can be given in the form of sustained release intravitreal implant or as an oral drug or intravenously. So intravitreal implant of ganciclovir, which is also called as Vitrasert, it's available in the 4.5 milligram capsule. It releases the drug with the rate of 1 microgram per hour for 6 to 9 months. But we know that CMV infection is a systemic infection, and therefore a systemic therapy is must. So therefore, an oral valganciclovir, which is a prodrug of ganciclovir, is given at the dose of 900 milligram 2 times a day for 2 to 3 weeks, followed by 450 milligram once a day. But the side effect associated with this is myelosuppression. Therefore, a CBC count should be monitored. And there are multiple reports which have shown that the oral valganciclovir is equally efficacious as that of the intravenous ganciclovir, and therefore can be used as a monotherapy. Now, there is an entity called as immune recovery syndrome, which is associated with HIV patients after starting heart therapy, after which after the patient's immune system develops, there will be inflammation like anterior segment inflammation, posterior synechiae, cataract, vitritis. There can be macular edema and also epiretinal membrane. So in such case, we'll start topical therapy of steroids. Now, the second viral infection is acute retinal necrosis. Now, it's a very uncommon entity and it's usually seen in immunocompetent individual. However, it can also be seen in patients who have immunocompromised conditions. So it basically presents with a peripheral retinitis. There will be multifocal peripheral retinitis patches along with occlusive vasculitis. There will be inflammation in AC as well as in vitreous. And there will be characteristic perivenular spreading. So it will give appearance of a cracked mud appearance. So the viruses responsible for it are varicella zoster, herpes simplex, and simplex 1 and 2 virus, and in some reports of CMV and EBV viruses have also been found out. So there will be a classic triad of panuveitis with occlusive retinal arthritis with peripheral retinal necrosis. The incidence of retinal detachment in ARN is around 50 to 73%. Now coming to the treatment, the standard treatment is giving intravenous acyclovir for 5 to 10 days. The dose is 10 mg per kg every 8 hours. And then adding oral acyclovir of 400 to 800 mg 5 times a day for around 6 to 12 weeks. We can also add intravitreal ganciclovir, especially if there is a severe vitritis or the optic disc is getting involved. In such case, we can also add intravitreal ganciclovir. Dose is 2 to 4 mg per 0.05 to 0.1 ml. Now the current trend is to start oral therapy alone. So there is a prodrug of acyclovir, that is valacyclovir, or we can also give a famciclovir. It has a better bioavailability than that of the oral acyclovir. So oral valacyclovir is given at the dose of 1000 milligram 3 times a day for 12 weeks and then slowly tapered. So it's very easy to administer. The patient is more compliant. The patient doesn't have to go to hospital for intravenous administration of acyclovir. So therefore, it can be preferred as a first line treatment in ARN. And basically, steroid doesn't play a mainstay of treatment in such cases. It's the antiviral therapy only. We may add steroid after 2 to 3 days of starting antiviral if there is severe vitritis or optic nerve involvement. Now the third infection is progressive outer retinal necrosis. So it's a variant of ARN. It is seen in patients who are immunocompromised like HIV, and the viruses responsible for it can be varicella zoster, herpes simplex, or CMV virus. As opposed to ARN, there will be minimal vitritis and there will be multifocal retinal opacifications which will be more confluent. And they have very early posterior pole involvement. Therefore, its treatment need to be started as early as possible. The treatment is intravenous ganciclovir with the dose of 5 mg per kg, 12 hourly for 2 weeks, followed by 5 mg per kg. We may also add intravitreal acyclovir if there is a posterior pole involvement. But it has a very poor prognosis. These are some other viral retinitis like subacute sclerosing panencephalitis, which is basically seen after measles virus infection. Its ocular involvement is seen in 50%. It may present with macular retinitis, chorioretinitis, papillitis, or optic atrophy. Now, recently, COVID-19 has also been found to be responsible for CRVO, CRAO, retinal vasculitis, and choroiditis. Now, dengue fever, it usually presents with retinitis and foveolitis. Chikungunya can present with iridocyclitis and retinitis. Now, what about investigations? So it's basically the clinical diagnosis, but sometimes ocular investigation can help us in conditions wherever we find it to be confusing with choroiditis. So OCT, again, as we had discussed, will help us to diagnose whether it's a retinitis or a choroiditis. Fundus fluorescent angiography will help us to know whether there is a presence of neovascularization. Now, systemic investigation of like serology titers can be done to look for the viral etiology. Sometimes we can also do a PCR of AC tap or a vitreous tap or a biopsy to confirm the diagnosis. But the diagnosis is primarily clinical. So to conclude, we suspect a viral etiology, especially when we have a large retinitis patch which are spread along the blood vessels associated with diffusely distributed KPs and high IOP. And we must start antiviral as early as possible. And recently, the trend is to start oral therapy alone. This will help to save the life as well as the eye. Thank you.
Thank you, Dr. Anuja. So, Dr. Anuja, can you tell other causes of retinitis besides viral disease which we need to keep in mind while treating a patient?
Yes, ma'am. Retinitis can be inflammatory or infective in etiology. If we talk just about infective, then it can be a bacterial also and fungal also. So, as I told that the viral etiology has a classical presentation that it spreads along the blood vessels. So that is very characteristic of viral retinitis. So that we have to keep in mind. The bacterial and the fungal, it usually involves the posterior pole, but the viral, they usually tend to present in the equator area or in the peripheral area.
Okay. So besides that, we have investigations also supporting.
Yes.
Thank you so much.
Thank you.